In this video, we will cover dyslipidemias. The term dyslipidemia refers to a group of lipid abnormalities that includes hypercholesterolemia, hypertriglyceridemia, mixed dyslipidemia, and low HDL cholesterol. Hypercholesterolemia, which is a raised serum total cholesterol and low-density lipoprotein cholesterol, can increase the risk of developing cardiovascular disease. There are 5 main classes of lipid-lowering drugs. This includes statins, fibrates, bile acid sequestrants, cholesterol absorption inhibitors, and nicotinic acid and its derivatives. The choice of lipid-lowering drug depends on the underlying dyslipidemia. However, statins are currently the drug of choice in the majority of patients with dyslipidemia due to the evidence that they reduce cardiovascular events. Statins are the drugs of first choice for treating hypercholesterolemia and moderate hypertriglyceridemia. Severe hypercholesterolemia or hypertriglyceridemia, not adequately controlled with a maximal dose of a statin, may require the use of an additional lipid-regulating drug, such as ezetimibe, and in these cases, treatment should generally be supervised by a specialist. Although statins are more effective than other lipid-regulating drugs at lowering LDL cholesterol concentration, they are less effective than fibrates in reducing triglyceride concentration. If triglycerides remain high even after LDL cholesterol concentration has been reduced adequately, fenofibrate may be added to statin therapy. Familial hypercholesterolemia is caused by a range of mutations in genes for the pathway that clear low-density lipoprotein cholesterol from the blood. Patients with familial hypercholesterolemia are at high risk of premature coronary heart disease. In all patients with familial hypercholesterolemia, a high-intensity statin, defined as the dose at which a reduction in LDL cholesterol of greater than 40% is achieved, is recommended as first-line therapy. Patients with primary heterozygous familial hypercholesterolemia who have contraindications to or are intolerant of statins can be considered for treatment with ezetimibe as monotherapy. If the maximum tolerated dose of a statin alone fails to provide adequate control of LDL cholesterol, a combination of a statin and ezetimibe is recommended. In patients for whom statins or ezetimibe are inappropriate, treatment with a fibrate or a bile acid sequestrant can be considered under specialist advice. The combination of a statin with a fibrate carries an increased risk of muscle-related side effects, including rhabdomyolysis, and should be used under specialist supervision. The combined administration of gemfibrozil with a statin increases the risk of rhabdomyolysis considerably, and so this combination should not be used. Statins competitively inhibit HMG-CoA reductase, an enzyme involved in cholesterol synthesis, especially in the liver. Muscle toxicity, such as myopathy, myositis, and rhabdomyolysis, can occur with all statins, however, it is rare. The likelihood increases with higher doses, and in certain patients, including those with a personal or family history of muscular disorders, previous history of muscular toxicity, a high alcohol intake, renal impairment, or hypothyroidism. In patients at increased risk of muscle effects, a statin should not usually be started if the baseline creatinine kinase concentration is more than 5 times the upper limit of normal. A repeat measurement should be taken after 7 days. If the repeat concentration remains above 5 times the upper limit, statin treatment should not be started. If concentrations are still raised, but less than 5 times the upper limit, the statin should be started at a lower dose. When a statin is suspected to be the cause of myopathy, and creatinine kinase concentration is markedly elevated, or if muscular symptoms are severe, treatment should be discontinued. If symptoms resolve and creatinine kinase concentrations return to normal, the statin should be reintroduced at a lower dose and the patient monitored closely. Thyroid function should be checked before starting statin therapy, and hypothyroidism managed adequately before starting treatment with a statin, as hypothyroidism is a reversible cause of dyslipidemia. Adequate contraception is required during treatment and for 1 month afterwards, and should be avoided in pregnancy as congenital anomalies have been reported, and the decreased synthesis of cholesterol possibly affects fetal development. It is important to note the different intensities of the statins, in particular the high intensity ones. You can refer to the table below for your revision as in the BNF. Common side effects of statins include myalgia, headache, nausea, flatulence, and dizziness. The risk of myopathy, myositis, and rhabdomyolysis associated with statin use is rare. Although myalgia has been reported commonly in patients receiving statins, muscle toxicity truly attributable to statin use is rare. When a statin is suspected to be the cause of myopathy, and creatinine kinase concentration is markedly elevated, or if muscular symptoms are severe, treatment should be discontinued. It is therefore important for patients to report any unexplained muscle pain, tenderness, or weakness. Statins have been associated with causing interstitial lung disease, and so patients should be advised that if they develop symptoms such as dyspnea, cough, and weight loss, they should seek medical attention. Before starting treatment with statins, at least one full lipid profile should be measured, including total cholesterol, HDL cholesterol, triglyceride concentrations, and non-HDL cholesterol, which is calculated as total cholesterol minus HDL cholesterol. Since statins are excreted by the kidneys, renal function should be assessed before starting treatment and reduced in those with renal impairment. Liver enzymes should be measured before treatment and repeated within 3 months and at 12 months of starting treatment, unless indicated at other times by signs or symptoms suggestive of hepatotoxicity. Statins should be used with caution in hepatic impairment, as there is a risk of increased exposure and should be avoided in active disease. Those with serum transaminases that are raised but less than 3 times the upper limit of the reference range should not be routinely excluded from statin therapy. Those with serum transaminases of more than 3 times the upper limit of the reference range should discontinue statin therapy. Patients at high risk of diabetes should have fasting blood glucose concentrations or HbA1c checked before starting statin treatment, and then repeated after 3 months. Patients taking simvastatin or atorvastatin should be advised to avoid grapefruit juice, as it inhibits the metabolism of these statins, increasing the risk of side effects. There are key dose adjustments due to interactions with simvastatin. With bezafibrate and ciprofibrate, a maximum 10 mg daily should be prescribed. With amiodarone, amlodipine, and ranolazine, a maximum of 20 mg daily should be prescribed. With some CYP3A4 inhibitors, a reduction in dose should be considered, and with verapamil and diltiazem, a maximum of 20 mg daily should be prescribed. With ticagrelor, a maximum of 40 mg daily should be prescribed. Thank you for watching this video. We hope you found it helpful.